So hi guys, welcome to our Sureshot series. Today we are going to discuss about the anti-arrhythmic drugs. This is one of the most important topic for your pharmacology, and these classification and their side effects and drug of the choice for which disease. This is all going to be framed as one of the most important topic for your FMG, NEETPG and even USML topic. So let's discuss this video. And before starting the video, I would like to say again, please do subscribe to the channel, and your support and your sharing and subscription will be make sure that we are going to provide the more content for you guys. Okay, so thank you so much. So let's get into the video. So before we start and discuss about the classification of the anti-arrhythmic drugs, I want you guys to know about the action potential of the ventricle. You have to know about the resting membrane potential. And the next thing is that is your depolarization. Another one is your repolarization. Always see the depolarization means you are actually getting the positive ions into the cell. Okay, this is always going to be the positive ions into the cell. And what is the repolarization? You are just getting back to your unpolarized state. Again, you are coming back to your resting membrane potential, that is your minus 90 millivolts. And what is the resting membrane potential of the ventricle? That is your minus 90 millivolts. Okay, minus, there is an influx of the sodium. So there will be an influx of the sodium and the cell will be going to the depolarization state, and it will reach at its depolarization state by the plus 30 millivolts. Okay, by the sodium influx into the cell, the depolarization state will reach plus 30 millivolts. The depolarization is nothing but your contraction of the ventricles. And next, here immediately after reaching the plus 30 millivolts, the potassium, the positive ion from the cell will be going out. So that is your potassium efflux. The potassium is going out of that. And after that, at some point, the calcium will be going to inside of the cell. This is the calcium influx. And here still the potassium is going to be going out only. Potassium efflux and the calcium influx is both going to maintain the cycle, and this is known as a plateau phase. Okay, this plateau phase is after that immediately still the potassium slowly will go out, and this will cause the repolarization, and resting membrane potential will be reached by minus 90 millivolts. So this is what our ventricle contraction will be occurring, and we have to know what are those different phases. This is your phase 0, this is your phase 1, and this is your phase 2, this is your phase 3, and this is your phase 4. These are the 4 phases. In the phase 0, sodium influx, and phase 1, potassium efflux, the repolarization will be start. And at the plateau phase, phase 2, the potassium out and calcium in, and phase 3, slowly the potassium will be going out, and the whole cell will be going to reach the resting membrane potential. And this all will be happening where? This is happening in the ventricles muscles. All right, and what we can understand, depolarization is nothing but contraction, repolarization is nothing but relaxation. This is, and now we will understand the classification of this particular anti-arrhythmic drugs, and who gave this anti-arrhythmic drugs classification. That this classification is given by the Wagen and William. The two scientists have found that the importance of this anti-arrhythmic drugs in the patients, those who are suffering from the severe brady or the tachyarrhythmia. So first thing is we have to know what are the different classes we have. Okay, class 1, we have the sodium channel blockers. Sodium channel blockers. And class 2, we have the beta blockers. And class 3, we have the potassium channel blockers. Okay, potassium channel blockers. And class 4, we have the, that is your calcium channel blockers. And class 5 is your miscellaneous drugs, and this can be considered as so many drugs that can include your adenosine, atropine, MGS44. All these drugs will be coming under the class 5 classification. You can remember Sonali Bindra and Priyanka Chopra. Okay, by that you can remember these 4 classes mnemonic. So let's dig into what is the classification and what are the importance of this classification. So let's start with the first classification, that is your sodium channel blockers. And remember that in the sodium channel blockers only we have the 3 sub classifications also. How these 3 sub classifications is divided means based on the sodium and the potassium. So first 1A is going to be with your sodium channel blocker, and at the same time potassium channel blocker. So both channels are blocked. All right. And next 1B. 1B is going to be potassium channels are open and your sodium channel blockers are blocked. All right. Next 1C is more like close and sodium channel blockers are very strongly closed. Okay. Very strongly closed. So this is how the sub-classification is done. 1A is a sodium channel blockers is closed and the potassium channel blockers closed. 1B, potassium is open but the sodium channel blockers is closed. And 1C is where potassium and sodium is closed but the sodium is more strongly closed. So here you can see how this is completely changed the graph of the action potential of the ventricle, because see, when you suddenly your sodium channels are blocked is closed, then the action potential will be, the duration will be increased. All right, here you can observe the action potential duration is increased in the class 1A. And class 1B, when we are actually not blocking, the sodium channel is blocked but potassium is open, and here your action potential is decreased because potassium channels is already open, all the efflux will be happening and the action potential will be decreased. And 1C, that is very strongly closed, sometimes it is just normal action potential only we will be seeing. And what are the drugs that we have in the 1A? That is your quinidine, prokinamide and the dispyramide. And next 1B, you have the lidocaine, mexiletine, and also you have the phenytoin. The phenytoin is also classified in the 1B. And 1C, you have the flecainide and the profafenate. And what I have to emphasize is the importance of these drugs. Where we use the prokinamide, okay, prokinamide, we have only the IV form. So this IV form is given in the patients, those who are suffering from the WPV syndrome, with those who are associated with the AFib, okay, atrial fibrillation and Wolff-Parkinson-White syndrome, we can give this drug. Okay, but these drugs can cause SLE, because you remember the ship mnemonic, the prokinamide is also one of the drugs. It can cause the drug-induced lupus reaction, and this can cause the QT prolongation. Why QT prolongation, guys? Because we are actually blocking the potassium and the sodium channels. That's why it can cause the QT prolongation. And the next drug, you have the quinidine. Quinidine is actually the best anti-arrhythmic drugs given in the SVT and the PSVT, and this drug can cause the synchronism. The patients, those who are having synchronism, and patients can also have the low BP. And the next drugs that you have, dispyramide, this can cause the anticholinergic, where this can cause the anticholinergic action, and that's why it is not given in the patients those who are having the anti-arrhythmia at the same time that the patient is having the heart failure. So we will avoid the dispyramide. And the lidocaine, you all know lidocaine can cause the malignant hyperthermia. And next, coming to the other drug, you have the flecainide. So this flecainide is actually given in the patients those who are suffering from the Wolff-Parkinson-White syndrome from the chronic time, so that we can give the flecainide. And the 1C, the one thing that you have to remember for the 1C is they are pro-arrhythmics. Okay, they are the pro-arrhythmic drugs, so we can avoid in the anti-arrhythmia. Next, coming to the class 2, the beta blockers, you have the metoprolol and atenolol and the propranolol and esmolol. And here you can see, when we have completely blocked the beta channels of the heart, beta 1, the receptors present on the heart that we are actually trying to block. And what it will do immediately, it will decrease the heart rate, and immediately this action potential, the decreases slope of the depolarization at the phase 4 we will be seeing, and prolonged repolarization of the AV node. Simply it is going to block the AV node. Okay, in the simple words, if you want to understand the mechanism, the beta blockers is going to block the AV node. And what are the best drugs we have? Esmolol is actually in the IV form. We can give the SVT and patients those who are having the post-arrhythmia, post-MI anti-arrhythmic drugs, and we can also give the esmolol as a choice. And next, coming to the side effects, you all know what are the side effects of these drugs. It can cause the hypoglycemia, right? It can cause the hypoglycemia, it can cause the asthma, and it can even cause the constipation, impotence. Okay, patients those who are using the long term of the beta blockers, they can also have the impotence, and those who are having the COPD also, we don't have to give the beta blocker drugs. And the best drugs are the beta blockers only, because it is actually preventing the post-MI or decreased by this. And even we can give for the acute SVT and PSVT. And next, moving on to the class 3 drugs. These are the one of the most important drugs, not even in the examination but also in the private practice, because see, these channels are potassium channel blockers. What will happen? The action potential will be increased and it can cause the QT prolongation. The most common side effect of this classification is the QT prolongation. What is the QT prolongation can cause? Torsades de pointus, right? Torsades de pointus will be seen in this patient, and immediately we have to retrieve that arrhythmia. We can save this patient by what is the drug of the choice, guys? That is your MGS44. MGS44 for the torsades de pointus. What it will do? It will decrease the QT prolongation and it will decrease the action potential duration. And what are the drugs we have? Amiodarone, sotalol, and ibutylide. And this is the most commonly having high risk of the QT prolongation is the ibutylide. This can cause sotalol. It is a LOL. This is a beta blocker, but at the same time, beta blocker action and also calcium channel blocker. That's why it is classified into the potassium channel blocker. And amiodarone, it is a very less likely to cause the QT prolongation. And I mean, the best thing of the amiodarone is it is the most widely and most commonly accepted drugs for the all kinds of arrhythmias. We can take the SVD, PSVD, AFib, heart blocks, anything, but we can give this drug, the amiodarone. It is the most arrhythmogenic, anti-arrhythmogenic drug, but it will be coming with the side effects. What are those side effects? One is your pulmonary fibrosis. It can cause the pulmonary fibrosis in the patients, and even it can cause the hypothyroidism. The patients who are suffering from the thyroid diseases, but already you are giving this drug, it can cause the thyroid disease because it is the iodine formulated. 40% of the drug is iodine formulated. That's why it can cause the hypo or even hyperthyroidism. And patients, those who are using this drug, it can cause the liver function test are deranged and corneal deposits we can see in these patients. And these patients, the common syndrome we see in the dermatology, that is your blue man syndrome. The blue man syndrome is also seen in these patients, those who are taking the amiodarone. Why amiodarone we prefer? This is actually a long-acting drug. The long-acting drug we give in the anti-arrhythmia that can suppress the anti-arrhythmia for the long term. That's why it is even in the follow-up of these patients we write the amiodarone as a drug. So these are the side effects we see with the amiodarone. And last, the classification is your calcium channel blockers. We have the drugs verapamil and the diltiazem. It will also simply it is going to decrease the AV node or completely block the AV node. And drugs we have, that is your verapamil and diltiazem. Why we prefer this drug? Because those who are patients having the asthma, we don't give the adenosine. We don't give the adenosine and we don't give the beta blockers. These two drugs are not given. So those patients, those who are suffering from the calcium channel blockers, we can give the verapamil as a drug of the choice. And what are the side effects? Very less side effects we see with the calcium channel blockers. Mostly your constipation, or patients those who are having gingival hyperplasia or the edema can also be seen with this patient. That's it. So this is your class 4 drugs. And we also have the one more classification, that is your class 5. That is your class 5. This is actually nothing but your miscellaneous drugs. One is your adenosine. I want to explain here why adenosine is directly going to act on your great vessels. From the gate vessels it is going to act and it will immediately retrieve the patients from the PSVT immediately. And remember that not all the drugs are given rapidly, but adenosine is given rapidly, IV 6 mg immediately to the patient. Why? Because of rapidly, why we are giving? Because adenosine half-life is just 10 to 15 seconds only. Immediately you have to push by the jugular vein. We can give this drug for the patient, but it is avoided in the asthma patient and it can cause the flushing and immediately BP is decreased for these patients. And some other drugs you have the atropine. That is given for the bradycardia algorithm. The patients also suddenly having the bradycardia, they can give this one. And MGS44 already I have discussed. This is given for the torsades de pointus. And next other drug we have the ivabradine. This is a commonly used because those who are patients having the low BP and patients those who are having the low heart rate, we can give the ivabradine. Ivabradine is going to connect with the funny channels. Funny sodium channels it is going to connect and we can give this drug for the patients. And digoxin is also going to block your AV node. We can give for the PSVD, SVD long-term complications. So this is a classification that I want you guys to remember. So next week we will meet with the other topic, and meanwhile please read this classification and learn the side effects and the drug of the choice where we can use this drugs. And don't forget to subscribe and share this video to your friends.